Let's talk about how cancer develops. In the following slides, we're going to talk about the genetic mutation that has to happen. And then I want you to understand the characteristics of cancer cells and how they stay alive for so long and grow so aggressively. So we'll talk about transformation and their use of anaerobic metabolism, the way that they generate blood flow, blood supply, and then their immortality as well. So first, carcinogenesis happens because of activation of the proto-oncogenes, okay? And then there's mutation of these genes that results in this inactivity of the normal genetic output. Instead, there's an overexpression of these cancer-related products. And that prevents the normal functioning of the cell, particularly things like apoptosis, right? So now, instead of the cell behaving as one of the collective, so to speak, they now can go rogue and do their own thing. So remember that you have to have a genetic mutation, and the genetic mutation has to be more than one. In fact, it takes like 7 or 8 mutations before the cancer really begins. We'll look at that a little more closely later. So after the genetic mutation, there's this clonal proliferation and expansion that happens. And this allows the cancer cells to have a selective advantage over the neighbors because they aren't following the rules. That mutation means that they have gone rogue, so to speak. And there's this increased rate of growth, and it's not listening to the normal feedback of the surrounding cells or the rest of the body for that matter, and it won't respond to the Fas ligand, for instance, that would cause apoptosis to occur. So they really, again, have gone rogue. Now, these multiple mutations, remember, it takes several hits before this mutation can result in full-blown cancer. There's a stepwise accumulation of these alterations that occur in specific genes, and that activates these pro-growth pathways and the proto-oncogene that we've discussed and all those things. There's also blocking of the anti-growth signals, the prevention of apoptosis, as we mentioned, turning on telomerase and an activation of new blood vessel growth. And those things together allow tissue invasion and also distant metastasis as well. Once those cancer cells get into the bloodstream, they can travel. So the point to be driven home is that you need several mutations. And this sort of shows how this works. We start out with a normal cell up at the top, and a first mutation occurs here, but that's not sufficient to cause a tumor to develop, nor is the second mutation or even the third mutation, but rather it takes at least 4 and usually 7 or 8 mutations before there is malignancy that occurs. As an example, colorectal cancer, I should say, develops in this same pattern. So their first is normal epithelium to start, and then there's this hyperplasticity, right? The cellular adaptation strategy to become hyperplastic that eventually leads to early adenoma. And then that adenoma gets activated and there's an intermediate adenoma. Later on, there's more activation and reduction of tumor suppressors, and that causes a late adenoma. Once we get to loss of the guardian of the genome, P53, when you have loss of P53 or the guardian of the genome, that's where the carcinoma develops. And then we have invasion and metastasis and all those other things that go along with cancer. Now, what are the characteristics or the hallmarks of cancer cells? Well, we mentioned that there's this uncontrolled proliferative signaling, and that's from oncogenes like RAS and epidermal growth factor and things like that. They also evade growth suppressors, and the growth suppressors are those cyclin related things, P53 and PRB, that we talked about before. There's genomic instability, where the dysfunction of the DNA repair mechanism allows for more mutations to occur. And this is where we go from being a well-differentiated colon cancer, for instance, to being poorly differentiated as the mutations increase. You can't grow new cells, even cancer cells, without blood supply. They need sugar and they need all that stuff to grow. So in order for cancer to grow, there has to be angiogenesis. And we have developed in the laboratory different substances that allow for angiogenesis or allow angiogenesis to be turned off. So we would love for angiogenesis to occur in the heart so that people can have revascularization without having to have a procedure done, right? We would love to be able to grow new blood vessels to go around a circumflex lesion. That would be fantastic. The problem is that when we did that clinically, people were at a higher likelihood of developing cancer. So these two things kind of go balance each other out, I guess, or prevent the use clinically of that. We can either have no angiogenesis so that cancer cells can't grow and then people have heart attacks and strokes, or we can have angiogenesis that allows you to have revascularization without surgery, but then cancer is going to run rampant. So that's our conundrum that we have. Again, angiogenesis is required because you have to have a blood supply to feed those cancer cells. There is this replicative immortality. I love that. The telomerase on the end of the chromosomes avoids cell senescence. And we really haven't used that word before, but senescence is kind of the knowledge of its mortality, right? And knowing that that cell has a life cycle. When we have cancer cells, they are rogue and they don't know that they are supposed to die. They don't follow any directions. They don't have that senescence. And then finally, they resist cell death because they resist those signals from other cells to stop dividing, and they just keep dividing ad infinitum. So one of the early things that happens in cancer cell development is this transformation. This is where the cell actually becomes a cancer cell. And several things happen to cancer cells that are described here. One is that they are not anchorage dependent. In order for your normal tissues to grow, they have to have that cell-to-cell interaction. They have to have that protein that we talked about in the cellular biology chapter that tells them that they're part of the collective, right? But cancer cells don't need that. And so they can go about growing and reproducing when they are not anchored to other tissue. That's called anchorage independence. When these cells then form a monolayer or a single cell layer, they're supposed to stop dividing, but cancer cells don't do that. Cancer cells just pile on top of each other. And in doing so, they may cause themselves to outstrip their blood supply, in which case there may be some necrosis that happens, or they stimulate enough blood supply to just keep growing like that, and that's how the tumor develops. The really important part of cancer cells is their metabolism. Your cells in your body, your normal cells, reproduce aerobically. They use oxygen. We get whatever we said, 36, 38 ATP molecules for every molecule of glucose. And that's a terrifically efficient system. Well, cancer cells don't care about that. They just want to keep growing, and they're happy to just use sugar to do it. And in doing so, they use glycolysis, which is an anaerobic form of metabolism that only results in 2 ATP molecules, but they just continue to do that. They just use up sugar, which means that we may see lower blood sugar levels in cancer, and it also means that we may see higher lactate levels or lactic acid. We said angiogenesis has to happen, and there's plenty of secretion of these angiogenic factors. Telomeres and immortality, we talked about this before in the cell biology chapter. The telomeres are supposed to, every time the cell divides, they are supposed to shorten so that there comes an end to their reproductive cycle. But that doesn't happen in cancer cells. They just continue to divide ad infinitum without any mortality signals. Well, you knew it was going to happen. We're going to talk about inflammation again, because inflammation is one of those things that can lead to cancer. There's other things that can do it as well. There are infections that can lead to cancer, and there are immune responses that can lead to cancer development as well. So in this illustration, it talks about the cause of cancer due to inflammation. So remember that active inflammation is a predisposer or a precursor to cancer, because that wound healing response that continues all the time eventually goes rogue, and these malignant endothelial cells can develop. There are many different examples of this. The pancreas and the GI tract, the lower esophagus in esophageal cancer, ulcerative colitis, and many, many others. Another reason that inflammation leads to cancer is that inflammation is associated with all these cytokines, right? We talked about cytokines and how they influence things like fever, anorexia, etc. They also have an influence on hypercoagulability, and that's why some patients with cancer end up having DVTs. There's disproportional fatigue because, it takes energy for all those cancer cells to reproduce. There's suppressed appetite, wasting syndrome, and sometimes we can have endocrine-related problems like SIADH. So in tumors of the lung, for instance, they can be ADH secreting tumors, and that leads to the syndrome of inappropriate antidiuretic hormone. There are bacterial causes of cancer. We know about H. pylori. H. pylori was initially associated with development of peptic ulcers, but it turns out that even if we treat peptic ulcers when there's even if we treat H. pylori when there's a peptic ulcer, we still find that the patient, that's not curative of the ulcer necessarily. So when you say something about treating H. pylori to most gastroenterologists, they kind of give you that nod and shrug their shoulders. But the real reason to treat H. pylori is because of the development of carcinomas. And the reason that it happens is largely because of this P53 gene that is affected and that mutates in response to the Helicobacter pylori infection. Many viruses we know, probably most commonly is the HPV virus. Other viral associated cancers, of course, Epstein-Barr. We're going to talk about how that, or you will read about how that's associated with Burkitt lymphoma. Kaposi sarcoma from HIV. There's HTLV1 that's associated with a type of lymphoma and T-cell leukemia, chronic Hep B, chronic Hep C, etc.